Welcome to the Academy of General Dentistry podcast series featuring Dr. George Schmidt. Each episode features experts in the field of dentistry who share insights and inspiration to help you succeed. Let's get started. Welcome back, everyone. We have another great show for you today as we're going to talk about photogrammetry with our guest, Leila Zadeh. But before we introduce our guest, make sure you subscribe to our channel and hit that like button and ring that bell. That way you'll be the first to notified of all things AGD. Hey, Leila, how are you?
I'm doing well. Thank you so much. How are you doing?
I'm doing fantastic. Great to have you on the program. Really looking forward to our discussion today, and we're going to have a great talk. So before we get into that, let me just tell our audience a little bit about you. So Dr. Leila Zadeh is an advanced restorative dentist and a fellow of the Academy of General Dentistry. A dedicated teacher, she is currently an adjunct assistant professor at the NYU Langone Advanced Education in General Dentistry postdoctoral program at St. Vincent de Paul's Dental Clinic. She creates educational content for Spear Education and is a contributor to Spear Digest. And she teaches live prosthodontic continuing education courses with digitalDDS, specializing in AOX workflows, implants, and computer-assisted design. Using softwares including exocad, Mesh Mixer, and Blue Sky Bio, she was previously an assistant professor at the NYU Langone AGD postdoctoral program at the Arizona School of Dentistry and Oral Health's Advanced Care Clinic and clinical faculty at District Medical Group Dental Clinic in Phoenix, which she helped set up and where she treats medically complex cases. Dr. Zadeh is also a digital dental laboratory technician and a board member of the Chair of Continuing Education at the Arizona AGD. She's a member of the OKU and PBK societies and the recipient of the 2024 AGD 10 and Under 10 Award for the nation's top young dentists, and co-founder of the Phoenix Dental Study Club. She has nearly completed all requirements for her mastership in the Academy of General Dentistry designation, and we look forward to you getting that someday in the near future. Wow, that's a lot of stuff and a lot of tongue-twisting information for me to read. Sorry about that.
Thank you.
Yeah, so listen, what I want to talk to you about is photogrammetry, and you've got a great article on this coming out in the May edition of the AGD Impact, and we're really excited to see that.
I am too. I was so excited and wanted to share that I feel like so much of photogrammetry has been discussed in PROS literature or PROS journals, and I really wanted to showcase that to a general dental audience because it's something that can really help facilitate and increase the accuracy and predictability of restorations. It's not without its faults. So as I was writing this, I wanted to really give both sides, the pros and the cons. But for the right cases in the right practice, it can certainly help tremendously.
Yeah, I got a sneak peek read of that, and it's a fantastic article. And I'm sure our audience, our folks that read the magazine, are going to really love that. So let's just take a step back here. And for people that are not familiar with photogrammetry, just give us the brief overview of, what this actually is and, the definition of it. And then we'll talk a little bit about it.
Absolutely. So it is a technology that's been used in the military for many, many years, and it was used in the mid-90s for the first time in dentistry and proposed in 1999 to be used for taking the final impressions for full arch implant-supported prostheses. And think of photogrammetry as a way of making precise measurements based off of reference points in photographs. So what we really love to use that for in dentistry is being able to ascertain the spatial relationships of implants for a multi-unit prosthesis and how they relate to each other in space. And so that just makes it so much easier to do instead of the conventional way of like luting all the implant sites together with a jig and then cross mounting and all that back and forth. Being able to just take the extraoral scanner and get that information, take something that could have taken hours and hours and can make the doctor time in the chair time like 30 minutes. So it really, really speeds it up.
Yeah, I've done a lot of those cases myself. And like you said, it can literally take hours to sort of convert those kind of cases and do all that, as many of us know. And when I was reading the article, it can literally cut that time in half, right? With a lot of this work being delegated, I guess you can delegate this to your assistant.
Absolutely. I recommend, that just like before we do a final impression for even, crown and bridge, something that is more simple, it really, the onus is on the doctor to do that check of the final impression before it goes out for the final prosthesis. So what we often do is we'll have like, intraoral scans because one thing about photogrammetry is it doesn't capture the topography of the gingiva underlying of the arch. So you still need to have that intraoral scan as a supplement to the photogrammetry, which just captures the spatial positions of those implants. But if you are delegating anything to assistants to still, be present or to check and verify that. So I'll often do the photogrammetry scans, but sometimes that can be delegated to assistants as well. It's all about good communication and working as a team. And then before anything is, final sent to the lab, the doctor being a part of that and being involved as well. But it absolutely does cut time.
Yeah, so we'll get to the sort of the how and what you need to do to sort of get involved in this kind of stuff. But let me ask you this, because I mean, I've done a lot of digital dentistry over my career, crown and bridge and all that kind of stuff. And it seems to be, I mean, especially like crown margins are incredibly accurate. So why is it that, a regular scanner, it doesn't have the ability to do what photogrammetry can, and why do we need to use that?
That's a fantastic question. So I like to think of it as photogrammetry takes the accuracy of a desktop scanner and brings it to the mouth. Studies show currently just an intraoral wand scanner in and of itself doesn't do a very accurate and precise job of capturing those implant positions. There are newer technologies that are coming out. So this is such an exciting time to be in dentistry with, different things like the scan ladder product or different ways to create markers between each implant site to help the scanner kind of pick up that data to know where it is in space as it's traveling from one side of the arch to another, which is making the process more accurate. But currently, what we find is with something like photogrammetry, which has the ability to take the way that the cameras are within it, it isn't having the same stitching errors that going from one side of the mouth, kind of like a tunnel, just that can incorporate some error because the technology is trying to put all these images together, and sometimes it's okay, sometimes it's not, which is why it's so much more accurate when you use a wand scanner if you're scanning teeth, because the teeth are hard, they're static, they're not, moving like soft tissue would be. So it's easier for a scanner to pick that up versus just an edentulous space. It can get lost in space. And when we're talking about, having a rigid implant supported prosthesis onto rigid implants, that accuracy is so key because if we don't have passive fit, we can get biologic issues, we can get mechanical issues like bone loss around the implants from the active fit and the tension, or screw loosening. And so when we're talking in the world of where these like microns matter, you want to make sure that you're using some sort of a way, be it a conventional jig, although that takes time, and then, separating it and then re-salt and peppering, all these different things to reduce error. So one of the things I say to my residents and students is, in the digital world, the name of the game is reducing error. And however
Yeah.
we can do that, because it piles up.
I'm so glad you brought that up because I've always long thought that, 10 years from now, 15 years from now, and maybe even sooner, we're going to have a lot of problems with some of these bigger all NX cases because of many people don't understand the importance of the passive fit. And
Absolutely.
I think that introduces so much stress into the system, if you would. And as you said, you can get bone loss and, mechanical failure and all these kind of things. And so this is seems like a fantastic way to sort of make sure that we are checking all those boxes then.
It certainly can be. Another benefit of photogrammetry is like patient factors, like patient, face movement or blood, saliva, residue like that. It doesn't affect the scan the way that it would for an intraoral scan. So those are some positives. Some downsides though is that they can be very pricey. Each unit is different, but like the iCam that we use a lot in practice and that I teach on different workflows with it, but that's about $40,000. So if you're in a practice where you're occasionally doing one of these full arch cases, it may not make sense to use something like that. There are other photogrammetry systems that are much cheaper, but each has its pros and cons, and you also have to consider whether maybe using something like an OptiSplint or going the conventional route if you're doing them so seldomly might warrant doing that versus investing in a full photogrammetry unit.
Yeah, I want to touch a little bit more about that towards the end here. But so in the most simplest sense, we can almost think of this as sort of a loop verification jig then, I guess.
Absolutely. It is only capturing the positions of the implants in space and relative to each other. It's not capturing what the gingival architecture looks like underneath it. It's only the implant positions.
So then, walk me through, let's walk through that. Let's walk through how we would actually do this, in terms of, just let's pretend we have a case, but actually let me back up one more minute before we do that even. So you mentioned full arch cases. Can we use this for other things? Because there's a lot of folks out there that don't do full arch. And would this be something that would, if maybe you have a long span implant bridge or something like that, is this something that we can use for that also?
It can be used, yes, and I have for a couple cases that had multiple implants for an implant bridge. And so for that particular case, I wasn't able to, long story short, medically complex situation where we had resorbed bone. I had to have smaller implants than I wanted to have. And so I tried to over-engineer that site by adding more implants. So it was 4 implants, but they were shorter. And so in a case like that, I had Nobel compatible multi-units, and I was able to use my iMetric photogrammetry scanner to be able to scan that. But photogrammetry is not for like a single implant. It needs to be multiple implants, and it
Right.
just captures the relationship just like the conventional jig. That's a really good way of putting it.
Yeah. Okay. That's fantastic. So let's walk through a case. So let's say we have an all-on X 4, 6 implants, maybe in the maxilla or whatever the case. So how are we gonna approach this? And what's gonna happen?
So if a patient comes in, just like you said, let's say it's an upper arch, first I want to get scans as part of my exam of what the teeth looked like before and determine, do I like where the teeth currently are aesthetically, phonetically? Do I want to make any changes? And if so, what are those changes? So we take those initial preoperative scans of what the teeth looked like before as a reference. And then after that, let's say, all of the teeth are decayed and terminal dentition infection, all that, we take care of the infection, we extract all the teeth, but we've designed beforehand what we want those teeth to look like. You can either do that yourself with the system like Exicad, or you can have your friendly neighborhood dental lab do that for you. But you have now at this point, before you jump into surgery, you have your initial scans of what the teeth look like, and also your digital wax up of what you're hoping you want your final surgical interim to look like. So having all of that, many different ways of doing it. If you're doing guided surgery, non-guided, if you're doing the surgery yourself, or having your local oral surgeon or periodontist do that as well. But the key with photogrammetry is if you're using it either for your final prosthesis after everything's healed and you're done with your surgical interim, or you can use it to create a same day deliver a surgical interim as well. So it can be used for either flow. But regardless of what flow, the photogrammetry scanner, when you take it and scan, the dominoes are the scan bodies for the iMetric system, but each photogrammetry system has different scan bodies you put on. That just captures the implant positions. So that information is overlaid with your digital wax up of what you want your final teeth to look like. And then you also need to get an intraoral scan of what the gingival topography looks like underneath it, so that you know how much gingival pressure and where everything is supposed to be when you're delivering your interim surgical prosthesis or your final. So the lab takes all that information, and knowing where the implants are in space and what the teeth are supposed to look like, they can either mill temporary surgical or print a surgical interim that you can then deliver. The problem with the same day surgical interim is that the patient has to wait in the chair for the lab to finish designing it and then have it made. So that's one of the downsides with the same day surgical interim delivery. But yeah, those are kind of the pieces of the puzzle that you need to get.
So you mentioned a couple of things there. So, and you mentioned the dominoes, and I know I've seen some of these systems out there, and essentially when you're talking about these are basically for people that can't see or haven't seen this before, they're essentially sort of scan bodies that look like a domino, right? And they have little dots on them.
Yeah, the domino ones are specific for ICAM, but you're right. Regardless of which system you use, there'll be some sort of a scan body that has unique identifying markers on them so that when you take the photogrammetry scanner and it scans the arch, it's seeing those dots and each one is unique. So it knows exactly where those implants are in 3D space relative to each other.
And that's how it stitches together, I guess, based on the relationship of those. So when you say scan, right? So help us envision for what that looks like. Is it what does a scanner actually look like?
Yeah, great question. So different photogrammetry scanners might look a little different, but all of them are essentially some sort of it looks almost like a box or some sort of a device that's extraoral. You hold it in front of the patient's mouth. The iCam is really heavy. That's something that I was warned about, but when I tried to lift, I'm like, oh my gosh, I need to hit the gym more because I'm feeling the burn in my arms. But you hold it up and it emits the iCam a light, and then you look on the screen next to you and you can kind of follow, there's a circle and it guides you. So, this is just the iCam, but regardless of which photogrammetry unit you're using, it will give you prompts, either a sound or a visual circle guide where you're trying to get all you need to hold it up a little bit more on the patient or bring it a little to the left or a little to the right, just so that it can capture where all of those scan bodies are in the patient so that it knows where all those implants are.
So I was going to ask you about that. So of course, there's a learning curve as with anything. How long is the learning curve or something like this?
Oh, extremely quickly. Extremely quick. Now, the lab side, what then the lab will do once it gets all that information and how it will combine that, the implant position data that the photogrammetry gives with your design, your pre-design of what you want the teeth to look like, that is a little bit more involved and complex. And there's certainly CE for people if they want to learn how to keep that in-house, with the lab tech shortage and everything, people trying to keep more things in-house is something that can be learned, but it's not as intuitive as the photogrammetry clinically chair side is.
And what about labs? Are all labs going to work with this, or you have to use certain labs? I mean, how do we talk about that?
That's also a really good question. So as the popularity of photogrammetry has increased, in order to compete and kind of stay in the game, more and more labs have been having to get used to this. And many of them are also going and offering as like a service, because these systems are so expensive, going to offices with their photogrammetry units, and being able to provide that as a service. So physically bringing it to the surgical area if someone wants to use photogrammetry to do a same day temporary delivery for surgical interim or for finals as well.
And when you so let's back up a little bit. So these markers, are we taking off and assuming we're using multi-unit buttons, are we taking off the multi-unit buttons and putting them on? Do they snap on? How does that work?
Most of them are to the multi-units. To the best of my knowledge, only the PIC system can be direct to implant, but ICAM and MicroMapper and the other ones would have to have some sort of a multi-unit on it, which is something to consider if you are wanting to use photogrammetry for a multiple splinted implant bridge, for example. You need to pay attention to whether you are adding multi-units, how that would affect your restorative space, because the more hardware we add, that's something to consider as well. And so if you have sufficient restorative space for the multi-units and you're using a photogrammetry system like the iCam that would need a Nobel compatible multi-unit to use it, that's something to consider.
And so you're gonna go ahead and put those on the multi-unit. You're gonna do your scan.
Yes.
Then you're taking those off and you're going to do a regular scan
Yes, with your
with
intraoral scanner.
any intraoral scanner. And then what does it do? Is it create two separate STL files, if you would, and merges the two together? And
Correct. Yes, but the merging of all that is the magic that happens with the lab. The lab takes the STL files that represent the positions of where the implants are, and it can then link all that with, it's like data stacking. So you've got your initial, what the teeth used to look like, the teeth that were all crooked and everything, and then you have on top of that your digital wax up of what you want the teeth to look like. And then when you bring in the implant position data to that, you can then connect in a software like Exocad. There's ways to then connect all that information together. So you get implant positions and tooth shape and positions.
and so how involved is the clinician typically in a case like this? So you're going to gather all your information that we spoke about just a few minutes ago, and you're going to send that digitally off to the laboratory. They're going to do all this magic behind the scenes. The typical clinician, I mean, how are you going to come in along the way and they're going to show you what's going on, or are they basically just going to send you back a recommendation? I mean, how's that work?
Absolutely depends on the relationship between the lab and the clinician. Speaking from the perspective as a lab tech working in a lab and seeing, the way it is with clients, some clients want to have more input. Some clients will even do their own design, their digital design. They won't leave that to the lab. Some who may not have a 3D printer or may not have a 5-axis mill may want to utilize a lab to just do the CAM side, and they might want to do the CAD. So it's really, what's cool with these workflows is you can do as little or as much as you want to do. Learning how to do all the lab steps might involve, more CE, but it is something that can be learned. It's just a matter of, does it make sense to invest in all that, the equipment and everything to be able to do it? Or are there certain parts that you want to be involved in, like designing the interim prosthesis or the final, and just having, the lab just do the CAM side or different parts of it. So you can get as involved or not as you want in cases like this.
Yeah, that's good stuff. I'm sure there's a lot of people that really love this stuff and want to be involved, and others that, yeah, not so much.
Exactly.
So you mentioned investment. You already mentioned, some of the costs of the scanners, and I guess that's wide ranging. Um, what's the minimum I'm going to need? The minimum like requirements for hardware, software that I'm going to need. Am I going to need to go out and get obviously the photogrammetry camera, and am I going to need to get Exocad and other things to sort of supplement this, or what do I need?
Absolutely depends how involved you want to be. So part of the joy and the fun for me is being involved in the design. So someone who wants to be able to do the CAD side of it and maybe doesn't have the equipment to actually mill or print. If that's more of your interest, then yeah, investing in a software like Exocad would be a great idea. And some people who also work with labs and want to do some parts might do like part of the design so that some of it's done and send the rest to the lab to do like the fine tuning. So it's really as much or as little as you want, but Exocad is a fantastic and very powerful software to be able to do a lot of these full arch things. Whether it's just a complete denture, because sometimes we could, hope and pray that we'd be able to immediately load, but of course you always warn the patient that depending on, how the torque values are on those implants, you may have to leave with a complete denture until everything heals, and then we try again to do something final deliver. So Exocad allows you to be able to design everything from a simple crown and bridge to dentures to AOX type of a fixed detachable prosthesis.
Yeah. And so, you've had considerable experience with this, and even you were, lab technician gives you a whole nother sort of perspective on everything. What are some of the challenges that you found working with this technology, in the past? Some of the challenges that, that we may want to work towards in the future?
With using photogrammetry
Yeah,
specifically?
photogrammetry. In other words, maybe it's scanning, or some cases are not, that don't lend themselves as well as others. Maybe the maxilla, for instance, might be a better option, or the mandible. I mean, is it one easier than the other? Or is it just doesn't really matter? I mean, have you had any perspective on that, or could you share any perspective on that with us?
Absolutely. It's a really great question. So other than, the high cost, another thing that comes to mind where photogrammetry, you could think of it kind of like a downside, is that it's harder to check the accuracy and passivity of the prosthesis in advance and cement tie bases. With that workflow, there are workarounds like doing stone patties and fit and checking it on that from the lab side. But that is one downside, which has led to a lot of people starting to incorporate more direct to multi-unit screws to bypass tie bases. And there's a whole philosophy on that and whether to just use those for interims, which I'm more prone to do versus using it for final restorations. Another thing is another rule in digital dentistry, besides trying to reduce error at every step so that it doesn't accumulate, is alignments. Everything is when you're data stacking and you're taking what the teeth used to look like and what you want the teeth to look like and what the gingival scans look like, at the time that you're wanting to move on to the next step, like final restoration or for your surgical interim. And then you're also adding your SDL data from the photogrammetry of where the implants are positioned. All of these need to be, like the concept of cross mounting in the analog world, they all have to be exactly aligned to each other. And so when we are working on the mandibular arch, many times that is a little bit more difficult. There's workarounds with like fiducial markers and different ways that you can circumvent those issues. But generally speaking, to answer your question, when we work on the mandible where we don't have, all those wonderful rugae and everything on the palate that can help with alignments, there's more movable tissue, tongue, all these things. So aligning on mandibular arches from a lab perspective can be a little bit more challenging than maxillary. But there's workarounds and stuff for that.
Yeah, I was almost thinking of, from a patient management standpoint. In other words, some folks must be hard, the tongue and so on and so forth. But I guess really, the objective here is just to get the scan body. So if you can get in there with your intraoral scanner, I'm assuming because this is an extraoral scanner, the photogrammetry scanner is an extraoral scanner, not an intraoral scanner, then I'm sure that if you can get through that, you'll get through this, right?
It does make it a lot easier with a photogrammetry scanner, blood, saliva, patient movement. It's not as big of an issue as it would be for an intraoral scan. It does simplify that a lot.
Perfect. Okay, so we've already we've put the scan bodies on. We've scanned. We've taken our intraoral scanner. All that material goes to the laboratory. Is the lab send us back a PMMA mock-up of this that we're going to try in, and then we're going to go to finish, or are we just going to go right to finish? What's that workflow like on the backside?
Yeah, it depends on where we are in the process. So if we just send all that data for the lab to mill or print same day temporary for a surgical interim, then the patient would heal with that for a while. Once, osseointegration has happened, then we'd have the patient come back. We, do all our checks to make sure healing, everything. And then we'd have our final impression appointment after second stage for implant bridge. But it depends on if we're provisionalizing or not. For a full arch, then you would do another photogrammetry scan for your final. So then having a prototype or some way for the patient to have a milled or printed prosthesis to test out, see if they're happy with aesthetics, phonetics, and before we move on to our final, zirconia, expensive final prosthesis is definitely a good idea, and that's what we do routinely.
Yeah, that's good stuff. So really exciting technology. What percent of your cases are you doing this? Are you doing this on every all on X case photogrammetry, or are there times where you say we're still going to go old school?
It depends on what clinic you're in. So I teach and I used to see patients and be a lab tech for a pros practice that focused on a lot of these cases. And so pretty much all of them would get photogrammetry for either at some stage or another, either for the surgical same day prosthesis or for the final, just because it takes something that could take, hours, and it makes the doctor time, not having to run back and forth doing like, jigs and cross mounting and all that stuff. It can condense it to like 15, 20 minutes. So it really makes the process more accurate and streamlined.
Yeah, that's good stuff. So where do you think the future, I mean, it's an exciting time now. This is fantastic technology, but where do you think we're going with this in the future? I mean, what's the future going to bring?
I think there's going to be a lot more advancements on ideas kind of like the scan ladder or ways to improve the accuracy and reduce stitching errors for intraoral scans to kind of be a more of a competition for photogrammetry. So I'm excited to see what's on the horizon there on that front. That's very
So
interesting.
So what do you think the sort of the roadblock is for an all-in-one unit where we have photogrammetry and intraoral scanning in one unit?
Great question. So there actually are starting to come out on the market. So the Aoral Shining Elite scanner, you have to select different things. It's a slightly different workflow once you switch to the photogrammetry side of it, but it's one scanner. So you can use it for your photogrammetry and you can also use it for your intraoral scan as well. So it's coming.
Yeah,
Yeah.
I can't wait to see that. That's good stuff. So listen, like I said, I read your article and it's an amazing article, a lot of good stuff, a little bit more in depth than what we had the time to go into here. But for folks that want to get more training on photogrammetry, where they want to learn a little bit more, I mean, where can they go from a CE standpoint to say, if they really say, hey, I like this, I want to learn more, where can we find that?
Sure. So I teach some courses on photogrammetry with a company called digitalDDS, the surgical workflows, also the restorative workflows for AOX as well, different things to consider at the different stages. So we talked about if you're using photogrammetry for your surgical interim, what are some of the things you need on your checklist? And if you're doing that for your final and everything's all healed up, what you would need for that as well and things to consider. So there's great CE out there. I know Spear Education is also starting to teach more on those different types of workflows. So the information's out there. It's just a matter of deciding what makes sense for your practice. If you want to invest in a photogrammetry unit or utilize alternatives like OptiSplint or different technologies that are now coming on the horizon to try and reduce the stitching errors for those scan bodies. So you got to think of what do you want to invest in? How involved do you want to be in with the CAD side? I teach some courses on Exicad with digitalDDS. And so if that's something that you want to bring in-house and do that CAD side yourself, that's something that can be done. There's a little bit of a learning curve to it like there is with anything, but the dividends are well worth it if that's what you want to do and you want to do more of these cases.
That's really good stuff. And I'm assuming some of these, not some, but most of these companies, when you buy these units, they're going to have support and training available as well, I would imagine.
Yes, there
Yeah.
is some training with yeah. We do.
Fantastic. So you've got to share your contact information with us for folks that want to maybe take one of your courses, maybe have a question for you, want to learn a little bit more about this. How can we get a hold of you and how can we find out where you're teaching?
Absolutely. So I am on social media. So doctor spelled out DOCTOR_smile is my handle on Instagram. And so that's one great way to reach me. I also am on LinkedIn. So either a message on either of those, I'm happy to answer any questions. Anybody's interested in learning more or wanting to know how they can incorporate more of these technologies or pros and cons about any of them, I'm happy to answer. I'm a nerd, so I love this stuff and I love teaching.
Yeah, absolutely. And thanks so much for coming on the program. Really enjoyed the time we spent together.
My pleasure. Thank you so much for having me. It was so lovely to meet y'all.
Yeah, absolutely. And I also like to thank our producer, Kristen Gover. And if you like what you heard, please like and subscribe to our channel. You can always find us on AGD apps, Spotify, SoundCloud, Apple Podcasts, and on YouTube under @General Dentistry. If you have any questions, concerns, comments, or suggestions, contact us at news@agd.org. Thanks again, and we'll see you next time.